Thank you. Thank you, everyone, for being on the line. And thank you for inviting us to present on the successful return to work of cancer survivors. What is the research telling us to do? And in this webinar, we want to cover and hope that you'll learn about research-informed tips for cancer survivors, healthcare providers, and employers that can be implemented to foster successful return to work of cancer survivors. We will also look at what standards for practice have been developed to date that can guide a return to work of cancer survivors. And we'll also present some overview of parts of our bilingual Canadian website, Cancer and Work, that has been developed on latest evidence.
So before we jump into talking about the research, I want to introduce you to the Cancer and Work website, which aims to guide cancer survivors, healthcare providers, and employer representatives to support cancer survivors with staying, returning, and finding work. The website has been formed by 250 stakeholders who have prioritized the information they wanted. The website integrates information from research and best practice in vocational rehab and links to the best resources online in the world. Next slide. Yeah.
So, as you might have realized, cancer has turned into a life-threatening condition, for chronic condition for that sake, and that a large proportion of patients are faced with this new challenge. And we have to start looking at providing a more comprehensive cancer rehabilitation care to take this into consideration. We also know that employment and work-related issues in cancer survivors is increasing emerging area in both the research and the health as a health concern. And there was a report by CPAC, the Canadian Partnership Against Cancer, in 2012 that identified that by 2031, we can expect to have at least 2.2 million Canadians living with cancer. And that during their lifetime, nearly 1 in 2 Canadians will be diagnosed with cancer, and then more than half will report difficulty with returning to work or staying at work. There's also approximately 40% of cancer survivors who are between the ages of 20 and 65 years old, which means within the age of working. So this makes it a significant number of individuals who will experience a cancer diagnosis during an age where career and work-related issues play an important role in the individuals and the family lives. So we know that many cancer survivors are struggling not just with returning to work, but with sustaining work. And that there's this increased recognition of the employment and work consequences that happens consequently following a cancer diagnosis. There's also a systematic review that is exploring ongoing physical and psychosocial problems with cancer survivors and found that 1 in
We're losing Christine again.
Maureen, just jump in. Yeah, Maureen should just jump in.
Maureen, are you able to just jump in?
Hopefully. So let's see, 1 in 5. Let's see.
team and lower quality.
So
a systematic review by Menard in 2011 that identified that while 63% of working age individuals do return to work within that first year post-diagnosis or will continue working, there's 26 to 53% who will lose their job or quit during or after treatment. And there was a study by by Steiner in 2008 that looked at the impact of physical and psychosocial factors on work after cancer and found that although 92 out of 100 survivors did return to work, there was 57% who had to reduce their work hours by 4 hours per week, even 2 years after their diagnosis, leading for a significant decreased work productivity and loss with financial aspect. Okay.
okay.
Oops, sorry. Go down. Sorry. Okay.
Okay. So today we'd like to introduce the vocational model that we developed for the Cancer Work website. There've been various models, and it's just been recently published in the Canadian Oncology Nursing Journal in December. Compared to other models that have been out there, there's more attention on the psychological and system factors that might influence and have that don't have the same emphasis on the other models. So we're not going to try and spend too much time on the models. And I believe at the end of this is some references to other sort of vocational models that are out there. Next.
In terms of looking at this model, one of the factors, the biopsychological factors, that will include factors that precede or emerge or continue from the cancer that will influence the return process. And these can include the pre-existing condition that can result in a worse return to work outcome, but conversely, having a fair general health status and absence of comorbid illnesses before receiving a cancer diagnosis can facilitate the return to work after cancer. There is also disease and treatment specific. So we know that individuals with certain diagnoses have faster return to work rates, such as prostate and breast cancer, whereas lower rate has been noted with cancer of the gastrointestinal, female reproductive system, lung and head and neck, and grade 4 blood cancer and brain cancer. In terms of treatment specific, compared to surgery alone, a number of studies have reported that chemotherapy and multimodal treatment and mastectomy were associated with delayed return to work. As well, in terms of the prognosis or of the condition, such as recovery, the stability or the course of the cancer, or experiencing many side effects of the treatment, and if they're temporary or permanent, can also result in delayed return to work and can result in early retirement. In addition, those with lower projected survival rate of less than 2 years do have a higher rate of stopping work. In terms of illness representation and perceived workability, so individuals' perception of their own workability, in addition to their physical, cognitive, and emotional workability, are important influential factors in measuring chances of returning to work. And using Leventhal's model of illness representation, we see that it can exert much influence on the people's coping strategies when dealing with their perceived workability, which in turn can influence their functional, physical, cognitive, and emotional outcome. If we look at the report by CPAC in 2012, they reported that among the cancer survivors who perceived that having a diminished physical and mental capacity, that they were having more difficulty with finding work. Whereas cancer survivors who report less fatigue, less depression, or perceiving that they're more ready for work, they actually have an increase in work functioning. Here, so here when we know what we know in terms of the socio-demographics, is that gender and age and education does play a role in influencing the return to work, such as there was Dominguez 2018 that found an adverse effect on work with increased age. Increased age was also associated with early retirement and lower education. Higher education was, however, associated with a quicker return to work. In terms of men, they're also less likely to take 6 days, but if they do, they take longer than women. And in terms of education, like I said, higher education and exercise was positively associated with a quicker return to work. In terms of the meaning of work, including changes of priorities, there was a study by Marino 2017 that showed that there was a higher adverse effect for those who saw work as less important. And the study by Stewart in Toronto as well saw that, in fact, 41% of cancer survivors had a change in priorities with respect to work, and that 25% actually changed jobs. And with the expectation of recovery and the perceived workability, again, empirical studies have indicated that the importance of the patient's expectation of their recovery is a good predictor of return to work, and that a patient's own assessment of their workability and expectation of job success does well predict work functioning. And in terms of finally on the attitude towards work, there was a study by Dorland that found that high work ethics and negative attitude towards work affected their work functioning. But when there's high work autonomy, it facilitated work functioning and also facilitated return to work faster. And now in the next factor.
So system influences on return to work can include everything from financial support, wage replacements, how much and how long, and benefits, legal supports to support job maintenance, and other influences of the system such as medical rehab supports, familial, or cultural support. So looking at the economic financial supports of patients, those with lower household incomes were less likely to return to work. Financial strain, lack of financial reserves, and upcoming termination of sick leave benefits can result with having to return to work sooner, not necessarily coinciding with work readiness to return to work. In terms of medical system, we found perceptions of a healthcare team about work could influence return to work for the cancer survivor. And systematic reviews show that timely advice from medical team, assistance, and use of return to work services along with a return to work plan and resources can improve the cancer survivor's chances of being successful to return to work. In terms of legal supports, things like human rights may have an influence. Other findings associated with not a Monzel study or Drolet study in Quebec found that those that were in unions were less likely to return to work compared to others. In terms of family support, well, having outside support is a helpful factor to return to work. Having an overprotective family member or not having their support in the decision to return to work can negatively impact return to work. There's also been found that family issues like family moving or family illness or a family being laid off was a barrier to return to work, while family support was a facilitator. And finally, sort of cultural influences. In one study, Blinder in 2017, showed for those who were Chinese that were less acculturated to England and in the US and had lower income were less likely to be accommodated at work. So we're on to the next. So worksite factors play a role in return to work. So things like duties, pay, job demands, such as psychological, cognitive, physical demands, accommodations and support by the employer, and the relationship that exists in the workplace between the survivor, employer, manager, and colleagues. So as well, we see work duties. Worksite factors show a lower rate of return to work, include for those for manual work, blue-collar jobs, who are self-employed, working part-time, and have high-demand jobs. It has been found that women in low-income jobs are less likely to be accommodated by employers, and work accommodations such as schedule flexibility and graduated return to work are important factors in supporting job retention and return to work. We also see in terms of accommodations, breast cancer survivors with accommodating employers were twice as likely to return to work. And employers report having stressful work can be difficult for those with mental and physical challenges, which can include cognitive processing, memory, and fatigue. And then finally, workplace support from supervisors and co-workers are more likely to foster return to work. And conversely, less favorable work environments can provide more challenges for the cancer survivor who's working. Next. Ooh, that's me. So when considering return to work, it's important to consider sustaining employment. So we see that almost 10% more who had their workstation layout changed remained employed 5 years later. And supervisor support over 18 months was associated with increase of work functioning. And we also see an increase in quantitative demand is associated with reduced work functioning. And lastly, lack of monitoring and follow-up and wear-off of empathy by employers post-return has contributed to return to work difficulties. Next.
So when we're looking at the employer's perspective in terms of what are the barriers and the facilitators for them to be participating in the return to work of cancer survivors, the systematic review by Grennes in 2018, they highlighted the barriers and the facilitators, and they give as example that they have identified that, like Maureen said, offering support during the entire duration of the illness was perceived by both the employer and the survivors as a facilitator for work participation. And when this could be practical or emotional support, that was even better, such as providing time off work for medical appointment, reducing hours, also providing for sharing workload with colleagues and changing duties. Other facilitators is when they're providing genuine support and interest in the well-being of the individuals was seen as supportive. And as highlighted in the systematic review, to provide proper support also requires an understanding of the employee's capacity, their medical condition, the treatment, and the side effects, and how all of these are impacting on their work. It also helps when the insurance provider, the physician, have a good understanding of the work and the impact on work from the cancer diagnosis. And when looking at the many facilitators expressed by the employers, we see that they have a fair understanding of some of the implications, such as understanding that it's important to have an open communication using non-invasive means, such as email, but also seeking the survivor's preference on how they want to be reached and how often. And then employers also recognize that having it in place, a return to work procedures and policies also facilitate work's participation. And that and being well staffed and having staff to be able to cross-train for either the cancer survivor or when other staff take over parts of the cancer survivor's workload can also facilitate work participation. But then looking in terms of their barriers that was identified for the employers is that they do realize that avoiding discussing the topic of cancer is a barrier. They also recognize that the lack of knowledge and experience with the cancer survivor's medical information can be a barrier, but they also recognize the lack of support and access to medical specialists to discuss these issues and how to plan for the return to work. They also find it difficult to work around the unpredictability of the illness and the absence at work and having to manage the different conditions of returning to work. So perhaps they suggested appointing an independent third party, such as a doctor or psychologist, who could be the facilitator between these two individuals. Other barriers documented for the employers is their difficulty in balancing the interests of their business, the survivor's interest, the colleague's interest, and the temporary replacement of the survivor. They also recognize the lack of information about the legal options in relation to return to work in terms of what's their duties to accommodate and how far this duty to accommodate goes and in their ability to provide support for return to work. And again, from CPAC's 2012 report on employers' perspective, they also arrive at a similar conclusion with the lack of work policy, financial challenges by the organization, and how these were barriers for employers and how to obtain timely medical advice for the employer to properly plan the return to work of the employee.
So moving on to recommendations for employers, we'd mentioned earlier Canadian Partnership Against Cancer study in 2012. They interviewed 41 employers and 27 were in focus groups across Canada. So their recommendations that employers should develop disability management programs that include policy tools and corporate culture to support cancer survivor return to work, provide training and resources for managers and return to work. So one of the challenges we're seeing is that while HR and health disability managers may be aware of return to work resources, that may not be going to the supervisory level. They suggested prepare pre-formatted forms for physicians to complete in order to quicken the turnaround time for medical information. Develop return to work packages for employees, which can include return to work policy. They also recommended improving links to internal expertise and learn more about external resources that are available to support return to work. And also to create a fund for accommodation and to lobby government for tax breaks to provide accommodations and to prepare for accommodations. Also to be open to using a broader range of flexible work arrangements and to improve contingency plans. So identify contractors or cross-train employees in order to help cope with workplace challenges when a cancer survivor is off work. Next. So in Doers, this is actually, I believe, a PMH study of head and neck cancer. And this was survivors' advice to employers. And they had commented that they wanted employers to make the application for disability income easier, honor privacy but not pity a cancer survivor, provide accommodations and be flexible and be clear about constraints and expectations of the employer for return to work, be supportive, positive, and show understanding, have a plan in place on how to deal with cancer survivors in the workplace, to understand invisible disability. So for example, I may look good, but I'm still suffering from cancer-related fatigue. Learn about how cancer and its impact on work. Have a mediator such as a doctor to help define terms and navigating return to work. So next. So related to this, we had a study done by Dr. Kita from University of Toronto, who interviewed 40 cancer survivors, a service provider, employer representative, and they reported recommendations for accommodation. And the most common were graduated return to work, flexible schedules, modification of work duties, altered work performance expectations, retraining, and supports of the workplace to change the physical work environment. The challenges that they found is that as survivors have fears of requesting for accommodations, developing a clear and specific accommodations, jobs that accommodations were difficult to make. Things are more challenging if there were strained relationships between the cancer survivor and the employer before the diagnosis. Insufficient or inflexible workplace policies, and employers' concerns of productivity over accommodation, and worry about setting precedents for modifying the cancer's, accommodating the cancer as a deterrent to being flexible enough to provide accommodations. So next slide. So just finishing off with the CPAC recommendations, they additionally added that modified work schedules and flexible arrangements such as less hours, working from home, and compressed work weeks were helpful, and also recommended modified duty banks and modified duty programs as sort of pre-planning in order to prepare for a cancer survivor that may have to stop working for a period of time. Next slide.
This is now looking from not the employer's perspective, but the survivor's perspective from the systematic review with Grenadis 2018 in terms of barriers and facilitators. And they were identifying that they, out of the 47 studies that included cancer survivors' perspective on topics of support, communication, the work environment, discrimination, and perception of workability, the results highlighted that survivors receiving continuous support regularly from their employer as a facilitator, while the lack or no communication, was perceived as a barrier. They also have identified having respectful interaction as perceived as facilitator, and discussing the survivor's return to work plan, discussing the limitation and the possible work adjustment, and also being kept up to date in terms of the changes that are at work, reviewed as facilitators, and also for good work participation. They also identified having a good attitude and a good relationship with the work, and being able to recognize the survivors' workability and their strengths as facilitators for their work participation, and not just focusing on their limitation. As barriers, when it comes to barriers, the survivors noted that when there's lack of social, financial, and practical support from the employer, those are barriers, as well as when the communication is felt as negative, threatening, patronizing, and pressure. Of course, they also identified that a rigid, non-supportive, competitive, hard-nosed work environment as a barrier. Additionally, having a negative attitude, strained relationship, and overestimating the survivor's workability, especially for invisible limitations such as cancer-related fatigue, was acknowledged as barriers to work participation. And again, using the CPAC report, they also noted as barriers that struggling financially and having to come back early, or the lack of sick leave to recover, was a barrier, as well as having to face highly bureaucratic layers of approval for returning and completing all the forms. Maureen?
So moving back to the PMH study with head and neck survivors, the cancer survivors' advice to other cancer survivors is to encourage them to be proactive and understand the employer's perspective and be realistic about return to work. They made recommendations like take responsibility for health and take time to recover, that the oncologists advise recovery, not peers, be proactive, seek support and let people help them, set reasonable expectations and realistic plans for return to work, do not depend on employers to lead the discussion on return to work, consider disclosure, so weigh the pros and cons, stay in contact with the workplace, maintain positive interaction with those at the workplace, discuss return to work early and often with healthcare providers, and disclose the need for accommodations. So next page. So what we see is some mixed messages about whether the employee should share and what they should share with the employers. So again, in the Mckay study, we see there's a fear that disclosure may result in loss of prospects in job prospects for the future. The managers expressed concern that oversharing could lead to overburdening the colleagues. Managers fear that they did not want to ask too much and wanted to honor people's privacy. So some cancer survivors did not want to disclose just to maintain the feeling of normality. Survivors, psychologists, and managers felt that employers should be consulted, the employee should be consulted about what they need and how they want to disclose at the workplace. There were concerns that the survivor may withhold information by managers were concerned about this, and they may have unrealistic expectations. They may be in denial and push themselves too hard, not knowing what they need and not feeling comfortable with asking for what they want to need. There was a thought that not disclosing colleagues some information would lead to uncertainty and resentment from the colleagues. And in a study by Doyle, metastatic cancer patients, while they were struggling with being less productive, they actually did not and had concerns about asking for work accommodations to help them work more functionally. Next page. So realizing that stakeholders that they could benefit from better communication, we did create sort of two areas in the Cancer Work website. One is for all the stakeholders, cancer is teamwork and communication, and as well as for the cancer survivor, we have a section on helping them determine what to disclose, whether it's safe or not for them to do that. Okay, next slide.
And now this is from the healthcare perspective in terms of the from the systematic review again as well. What are the facilitators and the barriers for them to support cancer survivors return to work? And then what they had found is that when healthcare providers discuss survivors return to work plan, it benefits the work participation. And the Dewa study also found that when healthcare providers provide for a treatment summary, that the topic of return to work is more likely to be addressed, and that having a good relationship, like we mentioned, trust in between the professionals from the different setting is also helpful to discuss return to work and to implement a return to work program. In terms of barriers, the lack of clarity on the task of division for cancer care follow-up, including who initiates the return to work plan and the discussion and whose role it is, were seen as barriers. Discussing the return to work is viewed for some was mentioned as viewed as a lower priority in comparison to treating the cancer, and then that it and leads to the lack of information also between the hospitals and the primary care. And also waiting to discuss return to work until the treatment is completed was viewed as a barrier for return to work. And then the end, healthcare providers do not always feel confident about advising on work-related questions. And they do say they require support to enact this rule, and they'll need additional training for this rule.
So again, realizing that stakeholders could benefit from better communication tools in order to sort of encourage a more informed discussion in terms of moving forward. There's 4 sort of research studies looking at tools right now. The first is the cognitive symptom checklist at work, and actually was looking at people that were having challenges with cognition, and they fill this checklist out. It actually has been validated as being as effective, maybe even more as a neuropsych in terms of identifying challenges that may pop up at the workplace. Also, there's a return to work planner on the Cancer and Work website, initially developed by Dr. Mary Kita, then was adopted and modified to be an online tool. And it's been evaluated as being helpful and important in terms of helping in the assistance of return to work. As well as there's the Cancer and Work job analysis, again, who is just recently being researched and evaluated by Dr. Christine Mayu. And it was evaluated by 60 stakeholders and the research shows that it was a helpful tool. And based on the comments section, it's being revised, so can it be even more helpful? And as well, part of the same research study by Dr. Christine Mayu, we also evaluated the return to work planning tool. It's designed to improve communication amongst survivors, interdisciplinary healthcare providers, insurance adjusters, employers. And the employer fills this out with the cancer survivor inputting the information from the medical team in terms of restrictions and limitations, and comes up with a return to work plan. And I think what's unique is we just recently modified, recognizing that there needs to be consistent communication between the employer and a check-in between the employer and the employee, and it needs to continue on well after the return to work plan is finished. Next slide. So reviewing interventions, there hasn't been much. There's been a real dearth there, and but they fall into sort of hospital-based programs, educational information like leaflet, traditional rehab, counseling, a case management report, and then Christine's going to talk about the Cochrane review. But in terms of, next slide.
So in terms of that Cochrane review for evaluating effectiveness of intervention on outcomes of return to work and quality of life by Dewa in 2015, they evaluated the effectiveness of 15 randomized clinical trials, so RCTs, for intervention to enhance return to work for cancer patients and on quality of life. And among the 15 RCTs, there were 4 types of identified intervention. Most studies were with breast cancer for a total of 1,800 analyzed. And the main findings were that there were 2 psychoeducational interventions versus the usual care that did not result in higher return to work rate. In fact, they were similar and no differences on the quality of life. There was 1 intervention that provided for physical training, but then was not found to be more effective than usual care. And among the 7 RCTs looking at individuals who received medical function conserving therapy versus more radical treatment, again found that return to work was similar with no difference with the quality of life when compared to a control group. And among the 5 RCTs involving a multidisciplinary approach, including vocational counseling, physical, psychoeducation, they did find a higher return to work rate, but no difference on quality of life. But not surprisingly, though, none had specific intervention for vocational rehabilitation. So in conclusion to their Cochrane review, they found moderate quality evidence for multidisciplinary intervention to enhance the return to work of patients with cancer, not on quality of life. They recommend further testing of this approach in population other than breast, such as with colorectal and lymphoma. As well, they recommend that vocational components should not just be patient-oriented, but also be directed at the workplace or the work environment, including work adjustment and including the supervisors. So this is another systematic review, a recent one by Fong in 2018 that focused on examining the effect of psychosocial intervention with intervention components, including behavioral, psychological, education, and vocational, that aim to facilitate survivors' employment outcomes, including improving and measuring employment status, return to work, absenteeism, and time spent on work disability or sick leave. So they found 18 studies, 8 which were RCTs, and the other quasi-experimental. These were from 7 countries and then compiled for over 2,000 participants. And the results show that when cancer survivors take part in an intervention to support the return to work process, that they were more likely to be employed or have higher return to work rate in comparison to baseline. And this was translated into 68% versus 60%, and this difference was significant. But there was no difference for time spent on work disability or sick leave for those who took part in an intervention. So again, their conclusion is that the support provided in the interventions varied, as shown in this graph on the slide, and only 2 interventions directly addressed return to work plans combined with informational sessions. Yet the combined results are significant for any types of intervention support, but the authors caution that many of these RCTs that were collected in their systematic review had high bias, and so they recommend for additional, more rigorous studies before recommending any specific particular practice.
So looking at further in terms of rehab studies, I'm not sure why the Theta study, the first study I'm talking here about, did not make actually the Cochrane review, because they did actually have a hospital as another hospital as a control group, and they used high intensity exercise, and they found, well, there wasn't too much difference in terms of return to work, basically 2 weeks for those that were in the exercise program. What was important is there was a less reduction in work hours. So those who were in the intervention, it was 5 versus 11 hours in terms of reduced hours. And on long-term follow-up, 78 versus 66% return to work pre-diagnosis in comparison to the control group. And another study done with an occupational physician advice combined with exercise, well, they saw no differences of return to work. They did find that productivity increased to the point of 5 hours more a week in comparison. Next slide. So in other studies, there's one study that was done by Fowler, and they used standard care, and it's curious because standard care, and I believe this is an Australian study, was actually great. It's exercise, physiotherapy, OT, psychological, and vocational counseling. Versus the addition of a work-related functional capacity training. Well, they found no difference in role functioning. But I'd have to comment here that they were using a quality of life assessment, and I'm not sure that the assessment, the factor that they were using in this assessment would actually have separated out activities of daily living versus work sort of functioning. The next study was by Shepherd, and it was using health coaching and occupational rehab, and essentially it was 6 to 8 coaching sessions on physical, psychological, and spiritual well-being. And while there were no results in terms, they did find that it did show actually an improved work capacity as well. And then the last one was the nurse navigator, and this was actually one of the only ones that we've come across that is actually a work-centered approach. And they had a nurse navigator working out of, oh dear, I forgot the hospital. And basically he was coaching and referring to the company website. And what they found was there's low uptake, that very little people volunteered to be part of this. But for those that did participate, they appreciated the support of the non-judgmental and supportive approach by a nurse. So next page. So in terms of looking at hospital-based supports, this one was combining nurse or social work intervention and a letter from a treatment physician or to the occupational physician. So this is a European study. So essentially it's the treating physician, the oncologist to the occupational physician in the workplace, and meeting with the occupational physician, survivor, and employer to develop a return to work plan. They found no difference between the groups in the resumption of full hours and quality of life. But Mckay hypothesized that possibly that the hospitals that volunteered to do this were already motivated in terms of supporting return to work, and they wondered if they'd already, there was an intervention factor right there. So the next was an oncology occupational physician. So this was integrating such an expertise into the healthcare system, and they found that the satisfaction was high for the occupational physician because they had knowledge about cancer and work-related problems. Another study by Grunfeld looked at a self-guided workbook, which included exercise and goal-focused educated, and 30% of the controls versus 43% of the intervention group returned to work. And again, we haven't done, with the cancer work, we've gone as far in terms of evaluating the website, and what we're finding in our website is, so far, our viewers are sort of are showing satisfaction with the evaluation of the cancer work website. Next slide. So I want to zero here on, well, this isn't hardcore research, it is program evaluation. And what it was showing is, it was for patients that were participants in state vocational services. They found that for those that were not working or employment, a risk employment, 58% participants obtained employment. And they found that the services that were most helpful were vocational counseling, miscellaneous training, rehab technology, job placement, job search assistance, maintenance services, and those were successful, curiously enough. While they had more services, they spent time in the services. And a follow-up study by Chu, State Vocational Services, found that the services were different depending on whether you were returning to your former workplace or were looking for work. So the employed group received diagnostic and treatment services, rehab technology, and job accommodation, while the unemployed group received vocational training, job search instruction, and job placement. Next slide.
So this is, we've already mentioned some of these points, but it's looking at a Joanna-Brigg evidence summary that was done in 2019 by Whitehorn of return to work health professionals experience. And they reviewed the role of the general practitioner in terms of work-related concern and return to work in cancer survivors. What they found is that the treating physician, like we said, do not always feel competent about advising on work-related aspects. And they also consider that the specialist cancer nurse perhaps to be the best healthcare professional to discuss return to work because of her frequent contact with patients. But then, however, the nurses believe that the return to work advice should preferably be provided by the GPs or the general practitioners. And Barry's identified GPs to provide this return to work support were feeling like they do not know enough about the cancer survivor's job to provide return to work advice. And some GPs believe that providing return to work advice was outside of their scope of practice and beyond their expertise. So with healthcare professionals, there's really no consensus on whose role it is to initiate and to communicate with the cancer survivors on planning their return to work. There was also another study that suggested that occupational therapists perhaps were then the most appropriate healthcare providers, although there's concern about are they available and what would be the cost associated. Yet patients do appreciate, like Maureen just said, that the when advice comes from the oncology occupational health physician, because they're also knowledgeable about the oncology part in the workspace, and they're seen as more independent than workplace occupational health. They provide a greater awareness of work and the impact of cancer on work.
Well, our research study shows that a multidisciplinary intervention is sort of optimum in terms of supporting return to work. There's been a few papers out there talking about the optimum team that should be involved with it, one by Silver. And what we're also seeing is, while occupational therapist is a role that's, is being very involved with return to work, and in many settings, it seems to be missing from the research studies. And so the Desarian sort of talks about how OTs could very much contribute to supporting return to work for cancer survivors. And in terms of, I think, next slide, but in terms of that, this is one of the reasons in the Cancer Work website that we actually outline the disciplines and discuss how different roles can be particularly helpful in terms of supporting return and staying at work. So sort of finishing off, I have some recommendations with research, but also sort of a clinician hat. So I think what we're seeing is that there's a need to screen for risk factors early and often and intervene if it's indicated. There needs to be an improvement in assessment to improve access to information and work function for healthcare providers, survivors, employers with tools, training, and access to experts. We need to increase expertise and subsequent advice to healthcare providers and employers and survivors, how specific cancers and treatments might impact and provide suggestions to improve workability. For employers, it's important to foster supportive workplace. So to encourage both the employee and the employer to continue having positive communication between the employer colleagues and cancer survivors. It's also important for employers and actually healthcare providers to realize that we need to support sustained employment. So consider accommodation and financial supports to allow a person to return to work their capacity over time well beyond a graduated return to work. And there's the need to create multidisciplinary teams that are work focused, that include experts in OT, vocational rehab, and involve the employers. Next slide.
So we're getting at the end of our presentation, and before we move to the question period, which we're looking forward to, we also would like to highlight that we are currently conducting a usability and utility assessment of the Cancer and Work site. And so if you're interested, we're always looking for individuals to come and help us assess the usefulness of the website, but also in ways that we can improve. And we're also going to be implementing a few additional tools on the website that we're going to do usability testing of it. So if you're interested, just contact us, me or Maureen. And now, if we're going to turn it to the question period, and hope that you have some for us. Thank you.